Good morning, everyone, and thank you for being here today. Um, on behalf of the LLC, AFS LLC committee, we are very happy to be directing this motility course. My name is Danny Rad. I'm the medical director of the Hardware and Esophageal Center at University Hospitals in Cleveland, Ohio. This is my third time doing this course, and we are very happy to have you all here. This is a very nice, hands-on course that is supposed to teach everyone something about manometry, whether you're a beginner or whether you're, proficient in reading. We have something for you during this course. We'd like to thank our, companies, Labry, Medtronic, and Diversitech for providing technical support. And then I'm going to give it to my course directors as well.
Hi, everybody. I'm Adriana Lazarescu. I'm from Canada in Edmonton. I'm a director of Motility Lab and our Motility Fellowship program as well. And I'm very excited to be here today and to see so many people in attendance. And as Danny said, this is meant to be helpful to you. So I hope that you will ask lots of questions both during the lectures as well as in the hands-on sessions. And if you've brought cases, fantastic. We're happy to chat about those. Maybe if I can get a show of hands, how many people here are just starting out with motility, kind of feel like they're on more the beginner side? Okay, excellent, welcome. And how many people here have a fair amount of experience, just want to get better? Okay, great, it's almost 50-50, fantastic. Well, I think you're going to find that we have a little something for both groups, so welcome again.
And I'm Daniela Jodorowsky. I'm associate professor at Mount Sinai and director of the Motility Center there. So we're really happy to have you. I guess I wanted to ask one last question. Who here is within GI, medicine GI? Okay, and how about surgery? Okay, oh, a lot of surgeons, okay. Don't take our jobs. So I'm pleased to introduce our first speaker, Dr. Reveille. He's going to be combining actually two talks about introduction to manometry and also performing manometry. Dr. Reveille is the Associate Professor of Clinical Practice in CU School of Medicine and Chief of GI and Hepatology at the VA. So we're very pleased to have him speak with us today.
Good afternoon. Welcome to Colorado. I'm wearing the fall colors, less the aspens that are yellow. If you do have a chance while you're here to go up to the mountains briefly and see the aspens, they're going to be at peak. You hit the right time to come here to Colorado. I'd like to thank the organizers of AFS for asking me to be the lead-off speaker and for the team that you just heard from helping me get it together so I could talk to you this morning about, I think, some interesting things that even I didn't know about manometry. Now, the problem of giving this talk is you are now immediately satiated from your meal. I have approximately 30 minutes before your glucose rises and you begin to develop postprandial narcolepsy. So I'm going to need to get on this right away. Okay. I want to present to you a timeline of manometry. You may not know this, but this is a science that's actually been in evolution since the mid-1800s. The first manometer device was actually a mercury column device created by Frenchmen in the 1840s. In 1940, Engelfinger and Abbott developed a water-filled balloon with an external transducer. Probably pretty tough to swallow, but it was an interesting innovation and it moved us forward to the 1950s and 60s. In honor of Don Castell, an old friend of mine and mentor, many of our senior members of the faculty here and some who have gone before us were really the pioneers in creating esophageal manometry equipment to try to understand esophageal motility. And they're not limited to the names that I've listed here on the slide, some of whom are attending this conference this week. So one of the original papers was actually using intraesophageal manometer, and I'm going to just put these on the side and highlight these because really, is it not moving at all? Oh, I apologize. It doesn't seem to be rolling. Awfully sorry. We knew we were going to have technical difficulties when we started here today. Yeah. Let me get back to the top. Aha. The master. There we go. Thank you. Which one's the advance here? Yeah, okay, good. Yep. I see. There's a problem here. See, technical difficulty. Daniela told me there might be technical difficulties. Lucky me to be the first one up on the podium. Okay, so I actually cut my teeth using water perfusion manometry, and I will show you that timeline as we move along. But suffice it to say that Wiley Dodds, Steph, Walt Hogan, Ed Stewart, and John Linehan developed this paper in 1974 describing a system of a pneumohydraulic system like this. It's a schematic with a bunch of transducers, an infusion port that puts water through the catheter, and then strain gauges that also give you a type of pressure. Pretty neat. Let's move downstream just a few years. 1977, everybody remember Ron Arndorfer, the Arndorfer catheters? Okay, he and Dodds and Walt Hogan again developed a catheter system at the top using a nitrogen canister, pressurizing into an airtight cylinder with distilled water, deionized water, again providing a water column through a transducer and into a catheter. This is the kind of device that I actually cut my teeth on back in 1987. Shortly on the heels of that, we learned that small ports on little water perfused catheters, if you were studying the LES moves when you swallow. And so John Dent brilliantly said, well, we need a sleeve that will cover the entire LES as it moves up and down during deglutition. And thus we came up with the Dent sleeve. Now we move into the 80s. Now we're getting technical. The ability to miniaturize electronics and pressure sensors and transducers into catheters that are no more than, say, 6 millimeters, 7 millimeters, and at the same time put in multiple channels to record pressure. And now you see the evolution over the past 20 years or so. A four-channel catheter, they could be circumferential sensors or directional. Now we're cooking. Now we've got multi-sensors placed 1 centimeter apart over the length of the catheter. And if we really want to go further, go big or go home, now we have adding impedance rings to each of those sensors. So now we can study bolus transport as well as pressure and direction. So the timeline of esophageal manometry summarized here. Kronecker in 1882 with the first manometer, Ingelfinger in 1940s with the water balloon attached to a catheter. As we move into the 70s, when I became involved with this, strain gauge, water perfusion in the Dent sleeve. And that's me at the University of Colorado in 1987 as a third-year resident doing esophageal manometry on then the in vogue system, the TDS 12,000. And that's me at our Denver VA this year with a more advanced high-resolution motility system. The one thing I didn't put on this slide, and I apologize for those who are big flip enthusiasts, but I think that if you were to say, where's the next step? Where's one of the next steps that we're going? I should have probably added the flip technology into our esophageal motility armamentarium. So what about the equipment? Well, we have the 3 main vendors for the entire world here today, and we appreciate their involvement with our teaching and the support that they're providing us. The Medtronic device is called Manascan. Laborie markets the Solar system, and Diversitech, which is the local company here, is the Insight Ultima system. You can see they're all pretty much similar. They have a monitor, which lots of pretty colors, and they have a computer, and some of them have printers, and they all have pressure transducer interfaces. But what else do we need to perform manometry? We need good software, high-resolution software. If you're not doing high-resolution esophageal manometry, you should be in this day and time. And you need an interpretation software, and the thing I didn't put down here is you need brain power. Everybody in this room needs to be the brain that ultimately is able to interpret these studies and try to help our patients. Now, what about on the patient care side for the nurses? How do you set up the room in advance? Well, I will tell you, first of all, as you set up the room, be sure that you don't forget to calibrate your catheter for the day. And if you use different catheters and multiple patients, make sure you calibrate each and every time. But from the patient perspective, we ask the patient to come in with a very comfortable seating, usually sweatpants or something. We do provide them a gown on the front to cover that. Water-based lubricant, topical lidocaine or 2% viscous lidocaine. I use viscous through the nose exclusively. I don't spray the pharynx for most of the patients. Some water with a straw to get the catheter down, a syringe for bolus administration. Some of the tape that we like to use are the skin-colored tapes that seem to have a better adherence once we have the patient properly positioned and the catheter is in place. Saline if you're using impedance calibration, and then the patient may cry, but more often they're going to have nasal congestion either before or after the procedure, and provide them with some Kleenex tissues. So just the basics, salient, what you need to have. Don't forget about patient consent. I've seen several dialogues now over this past year on Doc Matters about who does consent. Should there be consent for esophageal manometry? I'm not here to answer that question. In the Veterans Health Care System, doing esophageal manometry is considered invasive and requires informed consent. And then our policies have pre- and post-procedure vitals after each and every procedure, be it sedated or not. So what are the current indications for high-resolution esophageal manometry? Well, clearly we do this because patients have trouble swallowing. Dysphagia when there's not an anatomic explanation. That's why we do manometry. Non-cardiac chest pain. Patients undergoing anti-reflux surgery. I think this is critically important for the surgeons nowadays when they're deciding on whether to do a lynx or a toupee or some tailored version of an anti-reflux surgical procedure. And for those patients who have postoperative dysphagia as well, I would say that I would complement that kind of testing with FLIP this day and time. Someone who's undergone a fundoplication, who has post-procedure dysphagia, I would probably do manometry and FLIP and try to understand what's happening with the compliance of that reconstructed GE junction. And certainly, if you're doing catheter-based pH or pH impedance testing, you should probably be doing the manometry for precise location of the LES and placement of the catheter. A caveat here, and this keeps coming out in all the position papers, the Lyon conference, and then work done by Phil Katz, Rena Yadlapati. If you're diagnosing GERD, you don't use esophageal manometry to diagnose GERD. I think everybody in this room understands that. There are certain patterns of manometry that may suggest that GERD is actually happening, but in my experience over years, many patients with GERD have a completely normal esophageal manometry. Therefore, you would miss a diagnosis. Contraindications, I think they're very few with a common sense. Altered mental status or someone who simply can't cooperate with the word swallow, that would be a problem. And also patients who have known or suspected upper aerodigestive issues. For example, patients who have head and neck cancer who have undergone radiation therapy may have an issue. And patients with anatomic anomalies such as a big Zenker's diverticulum, you'll be hard-pressed unless you place it endoscopically to get the catheter in place. So my reason for this introductory talk was simply, as I look around the room, I see motility and surgical providers of multiple generations in this room. And I think it's important for our senior people who have done this for over 35 years, and for those of you who are just entering the field of reflux and motility, that you have an appreciation for everybody that's done all that great work before you. And hopefully, if you're involved in academic pursuits, that you'll be able to make some contribution to the body of knowledge that we are rapidly accumulating in terms of understanding esophageal motility, both normal and abnormal. Okay. I'm curious, how many of you in this room have actually done a manometry on yourself? It's not too shabby. Voila. So from my days of water perfusion to my days of high-resolution impedance manometry, how do we perform a manometry? If you've had one done, you know it's not very pleasant. And when you're doing it, a lot of your patients are looking at you and saying, that's the worst thing I've ever done. And most of my patients remark when I remove the catheter, they say, you had that inside me? Okay, so these are just some of the nuts and bolts, practical aspects of performing manometry. The pre-procedural considerations, some of which I've already alluded to, but NPO after midnight for diabetics, and I think for the patients who are on Wegovy, the semaglutides, if we're going to follow the same guidelines for a 1-week hold for endoscopy procedures and surgery, we should probably do the same for manometry. Otherwise, it's clear liquids up to 4 hours. Remember that clear liquids empty the stomach not by peristalsis, but largely by changes in fundic pressure that pushes the fluid out through the pylorus. So we don't have to worry about peristalsis as much when we're talking about clear liquids. Again, comfortable fitting clothing. Now, the medication hold list that you might put on your patient instructions that you mail to the patient ahead of time may be variable depending on what you want to do, but there are classes of drugs that you should think about. All the medications that are anticholinergics, the antidetrusor spasm drugs for bladder, the drugs for Parkinson's, all the anticholinergics in that group. Prokinetics. I'm not comfortable that we have any prokinetic that we've ever had that can actually affect esophageal motility. I've yet to see one. If you're interested in research, you know, Colorado is one of the cannabinoid capitals of the United States. It's famous for being pioneering in that, and there's some evidence that cannabinoid receptor drugs may have a very powerful effect on impaired motility in the esophagus, but that's on the research side, so we don't have to deal with that at this point in time. Some of the anticoagulant, antiplatelet agents, we would have a usual withhold because we are going through the nose. You know, one of the big complications, one of the only ones I've ever seen, is actually a significant nosebleed in some patients. And there's quite a dialogue about patients on chronic opioid narcotics. Do you really want to test that patient with their symptoms on the narcotic or not? Well, that's a clinical decision. We know that acute narcotic effects on the esophagus have to do with peristaltic amplitude, but chronic narcotics, you know, we see these type 3 achalazias and the jackhammers, and we wonder whether some of those are due to the effect of chronic narcotic administration. So it's simply a decision. Understand what you're trying to look for, and if it doesn't come out as the result, then take them off the medication. We've talked about the insertion of a catheter, but pre-insertion, we always do a sniff test. We ask the patient to give us a nice negative force inspiratory effort through both noses to see which one we can use better. I ask about patients who have had septal surgery. Please ask about nasal septal surgery. Do they have a deviated septum? And then we ask them to be sure their nasal passages are clear. I use a topical anesthetic, of course. Now, you might want to talk about patient position. The papers suggest that positioning in the upright with the neck flexed is the best way. Now, there's a beautiful video on YouTube of Dr. Reg Bell and his wife Kate inserting a manometry catheter. It's a snoozer. But sorry, Reg. I had to do that. He just retired, and I was at his retirement party. But that's probably still the best preferred way, but a lot of patients are anxious, and for me, what I often do is place them left lateral decubitous position and are more comfortable. They're used to that position, and pass the catheter through the preferred nair. When I get to about 12 centimeters or so, and I've gone past the hard palate into the hypopharynx, is when I give them a few sips of water, and I tell them, sip, swallow, sip, swallow, sip, swallow, with no breath. Almost as if we're doing a multiple rapid swallow, really, to get that catheter down and in place. There are some patients who have had tonsillectomy, with or without adenoidectomy, that have a nasopharynx posterior wall that's actually quite square, and it's hard to get something curved to go around a square turn unless, instead of being flexed, you have them extend. Have them extend until you get to that 12 to 15 centimeter. They'll feel it go down, you'll feel it go down, then flex the neck and swallow, and you're off to the races. So just a few different ways to think about catheter placement. Once the catheter is down at 45 centimeters in most patients, and per protocol with these manufacturers, then you can tape in place and you're good to go. Okay, and those are just these few tips and tricks that I've learned over the years. Now, what about if both noses are obstructed? Your right nose and your left nose is obstructed. Well, there's a little bit of workaround you can do. What I've done over the years is use a pediatric bite block orally. And I will actually pass the catheter orally as if I'm doing a small endoscopy, an unsedated endoscopy, and pass the catheter down that way. Now, they're not going to be able to swallow that way. I can remove the bite block, and I can pass this catheter into the posterior angle of the jaw. When I had my study originally, we were doing a lot of oral intubations, and you had to fashion it behind the back molar, and it seemed to actually be very comfortable. It's actually easy to swallow and sip water when it's back through the angle of the jaw. So just a trick. You might find yourself in a difficult spot, and you might remember that I told you about how to do this. Now, what about the patients that are too anxious or too gaggy, is what I call them? If they're too gaggy or too anxious, and I'm sorry, we have a lot of veterans who suffer many, many challenges because of their military experience, and many of them cannot tolerate intubation of this catheter. So, what can you do? Well, I think one of the quickest, slickest things, if you've got anesthesia available, is just give them a few hits of propofol. Now, we know that the first packed effect on propofol, you completely drop out your LES. In that first pass effect, in the first 15 to 30 seconds, most patients' LES drops out. But after that, it fully recovers, and when the patient is awake 15 to 20 minutes later, 5 half-lives of the drug have been washed out. And I find that the post-propofol manometry test is very easy to do for some of these hypersensitive or very anxious patients. When should we consider endoscopic placement? Be careful with the catheter. How are you going to get that thing? Are you going to grab it with a forceps? Grab it with a snare? Actually, there's a nice paper that was put out a few years ago where I think Dr. Pandolfino actually described a technique using a Roth net to grasp the tip of the catheter and pass it through the esophagus and into place. I find that usually I can get it down past the pharynx, and then I've got trouble distally, such as in a patient with achalasia, type 1 achalasia, very advanced sigmoid esophagus. You have no idea where you're putting your catheter. Put the scope in, grab the tip, take it down through the LES. The other group that we see at the VA are elderly veterans with huge paraesophageal hernias. The angulation of the esophagus into that paraesophageal hernia is acute, and it's nearly impossible to blindly pass a catheter across the anatomic GE junction to do that. So just some ideas of when endoscopic placement might be considered, in addition to the uber anxious patient. So our protocol now involves the latest adaptation of the Chicago 4 classification. What I'm showing you here really is a series of excellent technical papers done by all of our famous folks that are here today, and too many to name, but I thank them for all the work they've done. But the sum total is really putting together the Chicago classification version 4. So the vendors have now, I believe, I know that the Diversitech people have done this, put together in their acquisition protocol the steps that have been recommended by the Chicago 4.0 team and the papers behind that. Remember, these catheters are very fragile, they're very expensive, and also they respond to temperature. So there's going to be several parts of the study early on that have to do with warming up, warming the catheter to body temperature, and then making sure that you get a temperature compensation immediately upon exit, because the pressures will change rapidly in a cooling environment. So once the catheter is in place, patient's supine, left side down, and certainly no higher than 30 degrees angulation, even if they are semi-recumbent, we allow the catheter to equilibrate, warm up with the body for 60 seconds. And to be sure you're in the proper position, we then ask them to take a series of deep breaths. And look at the dynamic portion of the crus of the diaphragm when we ask the patient to take a deep breath versus shallow breath. Now you got your position exactly where you want. You set your anatomic position bars, UES, LES, and now you're ready for part 2. So the next step is you're going to take a 30-second time window, and you're going to measure resting LES, and for Chicago 4, resting EGJ, the UES, and the PIP-RIP, which is a pressure inversion point, or depending on your training, the respiratory inversion point, at which time you leave the abdomen and you enter the thoracic cavity. And with this technique, You'll have a 30-second time bar. It'll automatically close, at least in the Diverse Detect software. It automatically closes at 30 seconds. So easy peasy. Catheters in, patient's comfortable. You've done your assessment, your catheter's placed correctly, and you've got resting pressure. That's just the beginning. So the next part of the protocol involves wet swallows. You can use water or saline. I use normal saline. It does make a funny face on the patient, but I'm looking at impedance too, so I want to see a nice impedance clearance if I can. 10 swallows placed 30 seconds apart. That duration between swallows was figured out a long time ago. The closer you get from one swallow to the next, the more changes you may see. And I think that if you're going any faster than every 20 seconds, that you're going to potentially have problems. So we stand by the 30 seconds. The time bars don't lie in this software acquisition. Now, for those of you who've had this study done, you know that first few times that you swallow, it's really hard to swallow with that catheter. And patients have the same problem. They double swallow, they ineffectively swallow, something happens. So, you know, I give them a break. I often don't count the first 2 or 3 swallows unless they were pristine and they're right on. So I'm going to give them a break if they're having trouble. Some of the patients, just the presence of the catheter induces a constant swallowing reflex. And you're like, no, take a deep breath, slow, deep breath. And they still are swallowing every 5 seconds. And you can't possibly even get a resting pressure when you do that, much less legitimate swallow assessments. After you've done that, we move to multiple rapid swallows. This is still in the recumbent or supine position. And here, we're going to ask them to take a fraction of 5 mLs and repetitively, every 2 seconds, gulp, 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 and try to get them to 5, and then say, hold it, and then wait till you see a generation of peristaltic waveform at the end before you say it's a good study. It's difficult to do, and oftentimes you'll need to do it a second or third time, which the Chicago Protocol specifically recommends that you do that if you're unhappy with your first multiple rapid swallow. So this is all done now with water or saline in a recumbent position. I often do a second resting pressure before I move on to the next step. Sometimes the patient is anxious and your first basal resting pressure assessment really does not represent the anatomy as well. So I'll often grab a second resting pressure before I move on. So now we're going to place the patient in the upright position. We're going to repeat the wet swallows. A series of 5 is done in the upright position. And then we're going to do a rapid drink challenge. This time, the patient gets 200 cc's of water through a straw, and they get to try to chug it down all within 30 seconds. I'm not sure who created that, but that's pretty clever. Not everybody can do that, by the way. And please, if you see your water column rising in impedance in somebody with achalasia, you might want to stop before you drown them. Okay. I don't do meal challenges, but there's another way to understand patients who have specifically solid food dysphagia. The one thing you'd like to do is ask the patient, what is it that you have trouble swallowing? And if you can get that substance and repeat it to them, a couple grams of bread, a couple grams of popcorn, whatever's the thing that seems to cause them true esophageal dysphagia, and you repeat it, you can see that on the left, this is just a solid meal, and on the right, this is actually a whole meal ingestion. I think the problem with this is it might show you something, but at this point in time, we don't have a standard to understand what should be normal and abnormal. Let's say when I give you 2 ounces of ground beef and a nice dried up hamburger. I don't know what to expect. I hope you'll be able to pass it, but I don't know what to expect if the amplitudes are not within our current understanding of esophageal function. So from top to bottom, in Chicago 4 as the protocol, this is kind of how I do it. Are there some things I shortcut? Yeah, I do. I mean, I think if I have a normal recumbent study and I'm pressed for time and the patient's a pre-op, I may not do the multiple rapid swallows, or I certainly might not do the upright swallows or the rapid swallow challenge. I go down through the protocol further and deeper when I'm not seeing an explanation for why the patient has dysphagia. So I do a lot more work and take the full protocol if necessary, but only when I'm not getting the answers out of the front end of the protocol. And last but not least, I have to harp on this every time. Please don't forget, as soon as you pull the catheter out, before the patient remarks, wow, that was inside me, get the temperature compensation as close to it. You'll find out when we practice on the laptops today, if you want to play around with just the temperature compensation, the further down you move it, the more bland these colors will be, and the closer you move it to actually leaving the body, the more true measurement of LES pressure you will receive. I think that's a good way to do it. So when you're done there, exit the study, send it off to the physician for analysis and interpretation, and then process your catheter as appropriate with whatever your institution does to take care of these catheters. So I think I'll stop there. Does anybody want to swallow a manometry catheter today? Great. Thanks for your attention. Volunteer. She said volunteer.
Okay, so I'm pleased to introduce Dr. Adriana Lazarescu, who's one of our who's a course director. She's a professor of, I can't figure out the mouse, okay. A professor of medicine at University of Edmonton. Sorry, the mouse is not showing up. Oh, okay, got it. Still not, escape's not doing anything.
So this is the old presentation.
Yeah. Okay, great. Ooh, sorry, I just messed something up. Okay, there we go. All right, so she's going to review Chicago 4.0 metrics.
Thank you, Daniela. So my talk will be fairly basic, but I think that we need to understand the basics in order to build on them and do our interpretation for our studies. So how do I advance slides? Sorry, we keep having this issue. What am I supposed to push? Let's try. It works on my laptop, not on the screen, unfortunately. It doesn't go back. Sorry. It's back.
Did you hit escape?
Okay. All right, we're in business. All right, so we're going to just briefly review the definition of these metrics for manometry and how to identify them, and also how you classify swallows based on the Chicago classification. I always like to start with this slide, which gives a basic understanding of what swallows basically mean. So remember, the top third of the esophagus is skeletal muscle, bottom third, smooth muscle. In between is the transition zone. And when you swallow, the same impulse goes to the entire esophagus. But obviously, if the entire esophagus contracts at the same time, that would be counterproductive. So you need to have a delay, or so-called, what we call in manometry, a distal latency, or intrinsic latency gradient physiologically, in order to allow for the peristaltic wave to go through. You also want the contractions in the esophageal body to be of at least a certain amplitude in order to push forward the bolus, okay? So then lastly, you want your lower esophageal sphincter to relax in a timely fashion and adequately enough for the bolus to pass through. So this is actually, in summary, what we will be measuring on manometry. We're going to start with the distal latency, which is very, very important. So the way to think of this is your swallow starts the moment that your UES relaxes. Then there's this thing called the contraction deceleration point, which is in the distal esophagus within 3 centimeters of the proximal aspect of your EGJ. And so the time between the start of the swallow and the CDP is what your distal latency is. And I'll show you an image in a second. A normal distal latency is greater than 4.5 seconds. So if you have a swallow of a normal contraction amplitude, or DCI, with a distal latency of less than 4.5 seconds, this is considered a premature or spastic contraction. In simple terms, this is measuring the esophagus's ability to wait so that it doesn't contract at the same time from top to bottom. It slowly contracts over time along its length. So the distal latency is here, so from the very start of the swallow where your UES relaxes to the CDP, which is located here on your swallow. So if this is short, it tells you that the distal esophagus contracts too soon. And what might happen is it can contract either on top of your bolus or in front of your bolus, which obviously prevents the bolus from going through. Here is an example of a premature swallow. So the distal latency down here is quite short. It's less than 4.5 seconds. So this contraction happens too soon. So in that sense, it is a spastic, premature contraction. Remember that the esophagus is not meant to be perfect. If you have one of these and every other swallow is fine, then you're probably fine. And as you know from the Chicago classification, that you are allowed to have at least one of these if everything else is fine. If you have 2 or more of the premature contractions, then that is considered meaningful. We're going to move on and talk about the IRP, or integrated relaxation pressure. And this reflects how well your LES relaxes during swallows. You have to remember that your LES is not as if it relaxes completely, fully, 100% for the entire duration of your swallow. The relaxations do not have to be contiguous, and I'll show you an example of this. If you measure the LES pressure during a swallow, sometimes it's higher, sometimes it's lower, depends on respiration, depends on your contractions of your diaphragm and other factors, so it's not really open the whole time. It also depends on what your bolus is and how well your esophagus contracts, pushing the bolus forward, because there is a difference between your LES relaxing and your LES opening. Okay? You can relax your LES, but it may not open very well if there's really not much propulsive power or peristalsis coming from above. So for the IRP, we measure the total 4 seconds of essentially lowest pressure that the LES reaches during deglutition. In the past, like if you go back before the Chicago classification, we used to just measure the very, very lowest pressure the LES reached. But that was not practical. What if that happened for a nanosecond? So that's why we measure a total of 4 seconds. So again, in simple terms, how it measures how well the LES relaxes during swallows. And if you have an elevated abnormal IRP, that is part of the definition for EGJ outflow obstruction, but it's way more than that. So just having a high IRP is not sufficient, as you'll hear from other talks. So here's an example. On the left side, you actually happen to have an IRP that is contiguous. So these are the brackets for the swallow, and this white box tells you these are the 4 seconds of the lowest pressure during that swallow. On this swallow here, you see all these little white boxes that all together your software adds up to 4 seconds and averages for your lowest pressure. Again, nothing that you will ever have to do manually. Your software will do that. The only thing you have to do is make sure that the brackets or boxes, whatever your software does, that measure the IRP are located appropriately, because if they're in the wrong location, like sometimes I have seen, and this usually, say the software analyzes this on its own, if the brackets actually happen to be over here, you might have some of these white boxes over here, and they add up to the IRP, but that's actually an incorrect IRP because it's after the swallow. So you want to make sure that we are measuring the correct location. So What is a normal IRP? The correct answer is it depends. It depends whether you are supine, it depends if you're upright, it depends on software. So for Medtronic, supine less than 15 millimeters of mercury, upright less than 22 millimeters of mercury for Diversitech and Labrie. And for the upright position, less than 12 for Medtronic and less than 15 for Diversitech and Labrie. So it really matters the equipment that you're using, and you need to be familiar with that. Last but not least, we'll talk about DCI, or distal contractile interval. Basically, this is the vigor of the and contractile pattern of the smooth muscle portion of the esophagus. Remember, whenever we talk about motility in the esophagus, we're generally talking about the smooth muscle distal thirds of the esophagus. So when we talk about vigor, that's another word for strength. How strongly does the esophagus contract to push food through the smooth muscle portion? So a normal DCI is between 450 and 800. And you can see that the actual measurements are pressure, so millimeters of mercury, time, seconds, and distance, centimeters. And you'll see on the next slide when I show you a swallow what that actually means. If you have a weak contraction, that is between 100 and 450. If you have a failed peristalsis, that's less than 100, and anything over 8,000 is considered hypercontractile. If you have a weak contraction or failed contraction, those are ineffective swallows. So these are important when you're trying to measure how many of them you have for definition of IEM, or ineffective esophageal motility. So here are some examples. So in the DCI is measured in the smooth muscle portion. So again, you have distance from top to bottom, you have time from left to right, and then you also have the pressure that's measured within this area, which again your software will measure. Here's a swallow where the DCI is 204. So this is between 100 and 450. So this is a weak contraction, ineffective swallow. In this particular swallow, there's really no contraction in the esophageal body. It's a failed swallow, but also under the umbrella of ineffective. By comparison, here are some hypercontractile swallows where the DCI is greater than 8,000. In this case, 8,147. In this case, 10,000. I mean, it can be much greater. But I wanted to show you different appearance, if I can say that. So you can have a swallow that looks like any other peristalsis. It's just stronger with a high DCI. But often in these patients, if they have hypercontractile esophagus jackhammer, the contractions are often quite long. Like if you think between these thin, you can't even see them, but little white lines, that's 10 seconds. So this is probably close to 20 seconds of your esophagus squeezing. And these types of contractions have amplitudes of something like 300-400 millimeters of mercury, which is huge. It's above perfusion pressure. But anyway, when you're seeing these almost repetitive attempts of squeezing, that's when we call it a jackhammer as well. And as I said before, with premature contractions, your esophagus is allowed to mess up. So if you see one of these and everything else is completely normal, then you're probably okay. Remember, if you have two or more, that's when the Chicago 4 classification kicks in. So a one-off, it can happen for a variety of reasons. But really, if you're seeing more than one, then that matters. I mentioned that the DCI is both about vigor and pattern. So the vigor, how strong it is, what's your amplitude, but the pattern as well looks at whether there is fragmentation. So fragmented swallows have a break anywhere that's longer than 5 centimeters, regardless of the total DCI. So for example, in this swallow, the DCI here might be normal, but because of this break that you're seeing here, that is considered an ineffective swallow. The reason why is because you can often get a bolus escape through here, through this portion of the esophagus that doesn't contract. So on impedance, you could see that persisting. Here's one that has a much, much greater break. And in fact, if you were to measure the DCI here, it would be weak. So in this case, this is a weak fragmented swallow and still under the umbrella of ineffective. So in summary, Here's your distal latency down here from the start of the swallow to your CDP. The DCI reflects the contraction vigor and pattern in your smooth muscle esophagus, and your IRP looks at how well your LES relaxes during swallow for total of 4 seconds. I'm just going to mention briefly the provocative tests, the multiple rapid swallows and the rapid drink challenge. I know that Matt went through how to do them. Here's an example of multiple rapid swallows, 5 swallows in quick succession, and you're looking at the peristalsis at the end. You can also look at the IRP here. I usually work with Medtronic, so I can't comment on the other softwares, but for me to analyze the MRS, I actually force the software to make this a swallow, and that's how I measure like the DCI or the IRP, because these can be used, for example, in a patient where you think they might have ineffective esophageal motility based on their individual swallows. However, if they can mount a good DCI on the post-MRS contraction, that is called peristaltic reserve. So that tells you your esophagus has the ability to rise to the occasion, to contract properly if challenged. We also can look at the IRP. So if you suspect EGJ outflow obstruction on the individual swallows with a slightly high IRP, for example, if the LES can relax on the MRS, that actually is very helpful. I want to show you this example on the right. 1, 2, 3, 4, 5 swallows. And maybe a weak or failed swallow here. This is a beautiful example of secondary peristalsis. Be very careful where the wave comes from. The software, if you actually force the software to analyze this as a swallow, it will measure the DCI on this and tells you that's a beautiful, beautiful swallow. That's actually a failed swallow where the esophagus initiated its own peristalsis, secondary peristalsis, in order to clear itself out. So be careful about where the wave comes from. Last but not least, a word about rapid drink challenge. Before Chicago 4.0, we used to think that multiple rapid swallows, rapid drink challenge were kind of much the same. You just drank a little more, a little bit less, but really much the same. But it turns out that with large volume rapid drink challenge, you don't always get the peristaltic wave at the end. Don't panic, that's actually considered normal. So in this case, you can see that it did, but in this case, it did not. So that is something that can happen with a larger volume. The MRS, you should definitely have a peristaltic wave afterwards. With rapid drink challenge, it does not always happen, so just be aware of that. And again, for this one, if you want to measure the IRP, I just force the software to make this a swallow, and I put the brackets all the way from here to here, and I measure the IRP. All right, pretty straightforward. So in summary, short distal latency, that is a premature spastic contraction. High IRP, this is part of the definition for EGJ outflow obstruction disorders. And remember that there are 3 ways that you can have an ineffective swallow. You can have a weak swallow, you can have a failed swallow, and you can have a fragmented swallow. And that's that. Thank you very much. Any questions? Yes.
When you say that you force the software to do that, do you do it when you are actually analyzing?
Yeah, on analysis. So on analysis, what I usually do is I will analyze the standard swallows. I'll get all my numbers, everything set, and then if you actually go under the menu, you can say insert a swallow. So you'll insert a swallow and you can get the metrics for that particular one. Yeah, sorry. Okay, all right. So we're going to actually go on to the next speaker. It's my pleasure to welcome Dr. Amit Patel, who is an associate professor of medicine at Duke and also at the Durham Veterans Affairs Medical Center. And he is a very prolific researcher and educator and speaker in esophageal motility. And I will try to find his slides.
I think the slides are, So while we wait for that, so this lecture is intended to be an introduction and a complement to our first breakout session. We're going to talk about how we analyze study with a okay, well that's fine. We'll just start from here. So we'll talk about attributes of high-resolution manometry, how we position the catheter, and artifacts. Oh, it doesn't line up with the computer at all. Oh. I want to thank Dr. Gawali for a lot of the images in this presentation. So we'll talk about how we do basic analysis with the 3 commercial software programs, the Medtronic, the Diversitech, and the Library. And we'll talk about how, although these 3 software programs are developed independently, the way we recognize and identify motor patterns is very similar across all 3. And we'll finish with some clinical pearls. So this is a figure from our AFS textbook of foregut disease that we included. And so when we think about why we do manometry, obviously the first thought is obstructive esophageal symptoms, our dysphagia, our bland regurgitation. And if endoscopy is unrevealing, then we go to manometry. It evaluates esophageal motor function. We heard a little bit about provocative maneuvers, and we'll hear more about those. And then we have things like time to bright barium and flip that we'll hear more about through the conference. They're best thought of as adjunct, alternative, or complementary tests to manometry. With that being said, it's important to remember that across the spectrum of esophageal symptoms, not just obstructive, but also reflux, suspected, or atypical, that manometry can play a role in how we manage our patients. So for reflux, we talked about multiple rapid swallows, contractile reserve. For atypical symptoms, manometry can also help us identify behavioral disorders like rumination or supragastric belching. We heard from Dr. Reveley and Sandy talk about the evolution of manometry over time from conventional to high resolution. And specifically with these closely spaced sensors we have on high resolution catheters, we're able to generate these nice spatiotemporal Klaus plots that allow us to read manometry in a very intuitive way. And so when we think about our attributes of high resolution manometry, our upper and lower esophageal sphincters are visible in the same window. We have nice real-time visualization of catheter position. And so when the operator is doing the study, they're able to readily identify and address any issues with the catheter curling. These things are 3-dimensional. We have this intuitive depiction of motor function where we're looking at in a 3-dimensional way, right? We have time along the x-axis, the length along the esophagus on the y-axis, and then amplitude on the z-axis. And then we heard about those nice software tools from Dr. Lazarescu that we can use to identify or quantify sphincter function with the IRP, the timing of peristalsis with the distal latency, and the vigor of contraction with the DCI. The inclusion of impedance sensors on these catheters help us visualize bolus transit. And finally, the location of the LES is easily identified, so we can place reflux catheters in appropriate positions. When we have curling of the catheter, it generates these visually pretty butterfly patterns, but these are ideally identified and addressed in real time. On panel A, we have an example where the catheter curled in the esophagus in a patient with achalasia and moved retrograde. In panel B, it's an example where the catheter traversed the LES but coiled within a hiatus hernia and then moved retrograde up through the LES. And we'll hear from Dr. Tatum tomorrow about esophagogastric junction definitions, classification, morphology. But as we start getting larger hiatus hernias, it's increasingly important to make sure the catheter is traversing not only the LES but the diaphragm, if at all possible. And swallows can help us with that during the study. Why does that matter? Well, if the LES is not traversed, that represents a critical imperfection with a manometry study. As you might expect, this typically happens in achalasia spectrum disorders. And some potential solutions for this, the operator can have the patient stand up, raise their hands above their head, twisting on the catheter, repeated gulps of water, and we heard other techniques from Dr. Reveley as well, including placement under endoscopic guidance if necessary. In contrast, an inability to reverse the diaphragm represents a non-critical imperfection. We can still get a lot of valuable information from the study. And as you may expect, this typically occurs in patients with larger hiatus hernias. So swallow artifacts. If the operator recognizes these during the study, they're ideally rejected, these swallows, and additional swallows acquired. So things like dry swallows, belches, transient LAS relaxations, and double swallows should be identified and rejected during the study with additional swallows acquired so we can apply the Chicago classification interpretation algorithm. Vascular artifact. So the aortic arch, the left atrium, can create an impression on the esophagus, and that can result in these horizontal bars of pressure that we see. You can imagine that including these in the windows can artificially elevate the distal contractile integral. It can turn a study from ineffective esophageal motility to normal, for example. And so if this is profound during the study, the operator can ask the patient to tilt slightly to the left while they're supine, and that can allow the cardiac structures to fall away from the esophagus and minimize some of that vascular artifact. Sensor malfunction. So if there's a horizontal level of aberrancy that corresponds to a sensor, and that can occur if things like bodily fluids or cleansing fluids enter the catheter assembly. Software programs have tools to mask and interpolate adjacent channels to allow for a smooth contour. If that aberrant sensor is at the level of a sphincter, that can be problematic. So ideally, this is something that's identified during the study and rectified. So we'll go through each of the three manometry programs and talk about some of the high points and nuts and bolts. And if time permits, in technology, we'll try to actually go through a normal study together with the Medtronic software. So with the Medtronic ManoView software, when we open the study, many of you have started this morning to do that, this is how a study looks. So the first thing we want to do in the bottom left corner is change that time display to 1 minute to facilitate visualization. And thermal compensation we heard a little bit about. The idea there is that the catheters are calibrated at room temperature, but the studies are performed at body temperature. So at the conclusion of a study, the operator, after the patient is extubated, should hold the catheter aloft for a brief period. And that's a period of time where the catheter is at body temperature, but there's no pressure applied to it. And so our software programs can apply this. We want to move the vertical red line from Medtronic to just past the end of the study where the patient is extubated. And then under the Tools drop-down menu, we can select thermal compensation, and the software will apply thermal compensation to the study. And we'll see this throughout the software programs. So when we start interpretation, we typically start with the landmark box. And here we want to mark our anatomic landmarks. And so the upper esophageal sphincter, the lower esophageal sphincter, the EGJ. We heard about the pressure inversion point. And with the Medtronic software, we have these three dashed horizontal lines, green, red, and blue. And we can look for an area where that middle line is more or less straight, but the blue and green lines are inverted. With that being said, I want to make sure that you're not stressed over the exact placement of this. This is not a key part of interpretation of manometry. And so when we move through our swallows, we can click through them either by double-clicking or using the arrow functions on the bottom toolbar. The most important thing we can do with each swallow is make sure that the boxes and landmarks for our three metrics are appropriate. And so for the IRP box, Dr. Lazarescu described how that should start with relaxation of the UES and end with arrival of the contraction sequence. For the distal latency, similarly start at UES relaxation and end at that contractile deceleration point, or the curve of the hockey stick. And finally, the DCI box, we want to make sure that covers what we're interested in, S2 and S3. And we can drag and click these to make sure they fit what they're supposed to. With the Medtronic software, in the top right box with each swallow, there's also swallow designation that the software will try to fill in. And that can be intact, failed, panesophageal, etc. I also want to point out the capture button in the top right. When we're wanting to include images other than the standard swallows in our report, so things like the multiple rapid swallow, the rapid drink challenge, I find that can be helpful to include in the report. We can center that image and then click capture, and then we have the ability to include it in our report when we generate it. And so to create the report, top right, click report, and there it'll give us the opportunity to click which kinds of components or metrics or data we want to include in the report. And then there's also boxes for procedure description, where we typically use a templated procedure description, and then free text for things like indications, impressions, interpretation. And then click create, and we'll go through this when we go through a report, and then we can create a Word document or a PDF. And this is a sample report from our center showing some of the various things that you can include. And so it turns out to be quite long, but basically we have patient information, a swallow composite image, a lot of our metrics there, then the procedure description, impressions, interpretation, and then images for each of the swallows, the landmark phase, and any that you chose to include. Here I included an MRS and an RDC sequence as well, and then there's a swallow table. So you can include as little or as much of this as you want in your reports. Then we'll move on to Diversitech, Z-View. So when you open the program, this is how it looks. We have a list of the patients or studies on the left. So you choose the study that you're interested in reading, and then click Review Study in the bottom right corner. Thermal compensations we discussed. With this software, we use the green bubble that's highlighted in the pink box there, and double click on that, and that automatically takes the time frame to 1 minute. And then we want to move that vertical line for the thermal compensation to as close to extubation as possible. The landmarks, just like we did for Medtronic, we'll place with the Diversitech software. And so this includes the upper and lower esophageal sphincters. We have diamonds for the LES and the EGJ that should be placed at the points of highest pressure or warmest color on the studies. And then we can also place the pharyngeal, esophageal body, and gastric baselines with that landmark phase. And the important thing here is just to make sure that those aren't across an area where we have vascular artifact or something else happening. We want to move them to quiet, cool areas to facilitate our interpretation. And then similarly to Medtronic, we have the ability to click and drag to adjust our metric boxes. So for the IRP, we can adjust it however we want, vertically, horizontally, extend it. We can add or delete it as necessary, particularly if we're adding swallows. And our esophageal body metric, the same kind of thing for our DCI and our DL. We can click, drag, and adjust those to make sure that they're accurate. Because the software programs across all three don't necessarily do it as well as a human would. And peristaltic breaks we heard about, so we can also adjust that as necessary. Report creation generates all our data. We're able to pick and choose what we want to include. And then in our study summary, we have the ability to free text the impression as well as a diagnosis. So here's a sample report. And again, if you're including a lot of things, you can see this turns out to be very long, 10 or 11 pages. But patient information, our metrics, our impression, our diagnosis. We also have swallow tables here. And then we have thumbnails for each of the swallows along with any other images that we choose to include. So you'll see there's a commonality across the software systems. Third and final system, Labary. We open a study. This is the overview image. The timeline view is similar to when we open a ManoView study, for example. And there's also a shuffle view that Labary has where we can toggle through the swallows in this way. So the EGJ markers here are on the left. And so we'll mark the upper esophageal sphincter, the LES, and the pressure inversion point. With this software, there's red and blue horizontal lines, and we look for a place where those are inverted from one another. Again, thoracic and abdominal pressure. And the software metrics, similar to the other two programs, we're able to click and drag our DCI, IRP boxes to make sure we're including what we want to include for the software to analyze. The report creation for Labary is done similarly. We have the ability to include the various data and swallow tables. Over on the right, we can click which parameters we want to include in the report. And then the report will include a timeline view, any other images, swallow table, and of course the impression as well. So with that said, we talked about how these motor patterns look similar, but Dr. Lazarescu mentioned an important distinction, which is that the thresholds for IRP are different from Medtronic than the other systems. For Medtronic, they are 15 and 12 millimeters mercury, respectively, for supine and upright IRP, compared to 22 and 15 for Diversitech and Labary. That's important to keep in mind. We'll hear about the Chicago classification algorithm this afternoon. For the purposes of this talk, what I wanted to mention is showing you how those left-handed or left-sided achalasia motor patterns look very similar between the different software systems. And so this is Medtronic software, and what I'll show you is across the top there, we have examples of the three types of achalasia. They're all united by impaired EGJ relaxation. With type 1 achalasia, there's no body pressurization. Type 2, there's panesophageal pressurization. And in type 3, we have premature spastic swallows. So if you look at how types 1, 2, 3 achalasia look with Medtronic, if you compare that to Diversitech here, you can see how similar they look. And finally, for Labary, types 1, 2, 3 achalasia, again, visually very similar. And that's incredibly important because the single most important thing we do with manometry is adjudicate whether there's the possibility or suspicion for achalasia or if we're able to rule it out. And so some clinical pearls before we launch into a normal case. For the referring provider, they should always think about the clinical presentation of the patient and how a study is going to change the patient's management, whether it's a positive result, a negative result, or an equivocal result. For the reading provider, that's us. If the study is done for esophageal symptoms, the most important question we want to address is whether the manometric pattern supports or rules out an achalasia spectrum disorder. If it's done prior to anti-reflux intervention, the question we want to make sure we address is how the creation of an obstruction with an anti-reflux intervention, whether it's partial or complete fundoplication or magnetic sphincter augmentation, how that has the potential to affect the patient's symptoms. So what does that mean? We want to rule out achalasia, because then patients will need LES disruption. But we also want to address hypomotility. And we'll hear about IEM from Dr. Sloan tomorrow, but we want to address if there is profound hypomotility, how will that affect the creation of obstruction with anti-reflux intervention? And the biggest takeaway, of course, is to focus on the esophageal motor patterns that we see and the big picture in the context of the patient's presentation, right? We treat patients, not a specific number, and that's important to keep in mind when we're looking at these studies. So I think we have time to go through one normal study. So this is a normalish study with Medtronic. Before we do our breakouts, so when we open the study, we'll start by hiding the impedance for our purposes with this. When we open the study, we have the entirety of the study there. And so the first thing we want to do in the bottom left corner here is switch our time display from the entire study down to 1 minute, so we're able to appreciate these patterns. Then the next thing we'll do is take the cursor all the way over to the end after the patient's extubated, and we'll apply thermal compensation by taking the vertical red line and moving it to just after the patient's extubated, during that period where the catheter is closest to body temperature, but without any pressure. Under the tools drop-down, we have set thermal compensation. We'll click that, and then the software applies thermal compensation to the study. And so for interpretation, we'll typically start with the landmark phase, the resting phase, where we place our anatomic markers. We can move our box here, just clicking and dragging it to make sure we don't have any swallows at that point. And so it looks like our markers are already in pretty good position here. As I mentioned, that pressure inversion point, if you click the pressure inversion point, it brings up those three, the red, blue, and green lines there. And so we typically want to look for an area where the blue and green are inverted from one another, and the red line is more or less straight. We have the gastric baseline here as well. And then these so-called lollipops, where we take the LES and the esophagogastric junction. And so to interpret the swallows, we can either double-click on a swallow in the bottom toolbar or use the left and right arrows. And so when we bring a swallow up, we talked about how we want to make sure our metrics are reasonable. And so I'll adjust this gastric baseline a little bit up. So the IRP box, we want to make sure that starts with UES relaxation, which it does, and ends with the arrival of the contraction sequence. We have the distal latency here, and that looks like it's appropriate, starting with UES relaxation, ending at that contractile deceleration point, or the curve of the hockey stick. And then the DCI box appears appropriate as well. And so we can use the right and left arrows on the software here to move through our swallows in that way and make sure that all the metrics are placed correctly. The software will sometimes have a tendency to misplace things, and so we want to make sure that the software tools are being used correctly. They're powerful tools, they just have to be wielded correctly. And so we move through each of these 4 swallows. In the top right, I mentioned their swallow designations: intact, fragmented, weak, failed, panesophageal, absent. So we want to make sure that's accurate for the swallows we're looking at. And again, all these swallows appear nice and normal. All 3 of the metrics are in normal ranges, and we'll get into the weeds of that more later in this course. So all these swallows are nice and intact. And we went through 11 supine swallows here. And then I just want to point out, I had mentioned the idea of including things like the multi-rapid swallows. So when you're calculating the DCI for this, you want to make sure that the box just covers the contractile portion at the conclusion of this. This is a nice MRS sequence without a lot of noise, but when there is a lot of noise, we want to make sure that we're just capturing the DCI of that augmented wave, because that's what we use clinically. I mentioned the capture function in the top right. We can click that, and I'll show you how that's included later. What I'll typically have my operator do when they perform these studies with these extra maneuvers with the Medtronic software is use swallows to capture them. We'll take down the information and images we want and then remove these frames. Then we have a series of upright swallows. It's also important to remember that the anatomic landmarks often need to be adjusted slightly when the patient sits up from being supine as well. The upright swallows, as we'll hear throughout the course, are most important for their IRP in settings of EGJ outflow obstruction. And we can already see here that the landmarks do need to be adjusted for these upright swallows. So we can move all these slightly up. And the pressure inversion point as well, we had talked about finding a spot. And so that's usually best done with a landmark or resting phase after the patient sits upright. So we get the information we need, and then we'll typically discard these swallows. We can again capture any of them that we want to include as images for the final report. And then the final part of this study of the Chicago 4.0 protocol is the rapid drink challenge. And this is done in the upright position. And so we have this here. And so what we're most interested here is looking for panosophageal pressurization, which we don't have here, but also making sure that the IRP box includes the entirety of that rapid drink challenge. And you can see here we have a nice normal IRP at 2 or 3. I'll typically capture this to include it in the report as well. And then we talked about generating a report. We click in the top right on report, and so it brings us up the patient information, the various metrics that we want to include, and then there's an automated, by the software, a Chicago classification finding thing. I usually find better off editorializing myself with the various nuances. You have a template for procedure description that I suggest that if you're going to be reading studies that you generate to include, and that's basically describes all the steps taken with Chicago 4.0. The indications, we'll usually have our operator pre-populate those with the report, and then we'll put the interpretation or impressions. And there's different ways to do this, different templates, and we can talk about those more across this course to streamline the way you report studies and report diagnoses. And so then when we click the Create button here in the bottom left, it gives us a few options. I usually include a graphical report summary, which will include the images from the various swallows. And then also we talked about those screen images. We include an MRS and RDC sequence here in the bottom left. I'll typically lay it out in 2 columns, and then this can be generated as a PDF or a Word document, depending on your EMR. And so when you do that, let me just show you how a report looks before we wrap up here. Okay, there we go. So we talked about how we have the patient information at the top. The software generates a swallow composite of the swallows that were left in the software that we didn't delete, so the supine swallows. It'll have our various anatomic landmarks and our various pressures, proportion of swallows that were failed, weak, etc., or any procedure indications, interpretation impressions. And then it'll have thumbnails for the landmark phase in each of the swallows, as well as the additional screen capture things we did here. So we can see our MRS sequence and our RDC sequence here as well. And so you can choose how you can design and individualize these reports to what you're interested in sharing with your referring providers as well. All right, I think that's good, right? We're going to breakout sessions. Yeah. Oh. No, it's good. What's up, Danny?
So can you show where you place your gastric
Yeah.
sign, and then how this affects the IRP?
Yes.
And where you place it, because
Very good question. And so what I want to show you here is just moving the gastric baseline just a centimeter or 2 can really affect the IRP. So you can see where we started here was 15, right? That's borderline abnormal. If we move it proximal just a centimeter, it goes down to 14. If we move it distal, it drops a little bit. Actually, we didn't thermally compensate this. The gastric baseline, we want to place that at an area where it's quiet, it's cool, and patients with a hernia ideally would be distal to the distal extent of that hernia to the diaphragm. but small changes in the gastric baseline have the potential to affect that IRP. And so we want to use a quiet area, and then be vigilant for the idea that sometimes the IRP can be artificially or artifactually elevated. And that's one of the things that with Chicago 4.0 we're better able to address with upright swallows. But as we mess around with the software, I think it's important to see how little changes with where you place the markers can affect things like that. I think for this study, we didn't thermally compensate when I reopened it, and that's partially why it caused some of those issues. But that's one of the things that's most important when we read these studies. Let me try one more time. And that's when we get to this idea of, here, bless you, why, okay, now let's look at it. But usually in an ideal world, we'd keep it at least a couple centimeters away. And so you can see here, once we thermally, that's the other important thing to notice. You saw how this change of the swallow when we thermally compensated the study. Prior to that, it was close to 15 or abnormal. Once we thermally compensate, we're better able to see that it's more comfortably normal as well. Yep. That's a great question. Patients that have had gastric surgery, things are different. And obviously the classic example we think about is fundoplications, affecting our LES metrics. With gastric sleeves, we can see issues where the intragastric pressure, as you might expect, is higher. And so that is something to keep in mind, and that I think can have the potential to maybe mess with some of the numbers we're looking at. Because when that gastric baseline is artificially, using air quotes, lower or higher, then that affects what our numbers here look like, because they're indexed to gastric pressure. So it's important. That's a great question. Well, you don't see what you don't look for, right? So I think that's really important, particularly in the post-surgical patient. Do we have, is that covered, or is that, I know it's a little more advanced. In the cases we'll go through? Okay. Yeah, I think Danny's assembled a collection of challenging cases that we'll hopefully look at tomorrow, if not today. It's a great question. And so this sometimes comes up when there's a patient who's very tall and it's hard to get the UES and LES in the same window. And so what I've trained our operators to do the study is, obviously the single most important thing in the study is assessing the LES metrics, right? Answering achalasia or not. So we want to make sure there's enough gastric baseline. So I tell them if there's something like that and they really can't get both, then to try to do several swallows where they get the UES. But for the bulk of the study and the maneuvers, et cetera, to really try to make sure they have all of the LES and at least 2 or 3 sensors to have the gastric baseline. If there's really not enough when you read the study, it really leads to issues. And the worst thing to do, I guess, would be have to repeat a study. But if you truly can't make a designation for the patient based on that, then it can be kind of hard. Yeah. All right.
Thank you, Amit. All right. Yes, thank you, Amit. Of course. All right, so this is our first breakout sessions. Just a couple things about the breakout. So we have several laptops in this room. I think this side we have Medtronic laptops, and on this side we have Diversitech and Labry laptops. Am I correct? Yes, for the. Okay, so you have 3 different laptops. Obviously, we don't have 3 laptops for each participant. So depending on which software you're interested in, we're gonna have to share some of the laptops. We're gonna be splitting into 2 rooms. So whoever is here to learn the basics of manometry, who've never read one, they wanna take their time, we're gonna stay in this room. People who have had some experience and wanna a little bit of more advanced experience will move to the next room to the right. There are no computers on the right in the other room, so we have to take some of the computers. Please leave the chargers in here so that we can bring them back. Or actually, we'll probably leave the chargers in here so we can bring the computers back, because we're gonna keep them here and we're gonna keep moving for the breakout sessions. So whoever is novice, it's, beginners here and advanced move over. We probably have a little bit over an hour. This is very informal. We're gonna have maybe cases tomorrow. Today, we're probably just gonna play around with the software. The faculty that are here presenting, please, let's split ourselves between this room and the other room. We're gonna be walking around. Feel free to ask questions, sit down with the faculty, see what they do, how they do it. And we have company reps as well. They are gonna be very helpful. So please, if you guys can also split between the two rooms. This is our old computer, right? Yeah. So we just wanna put this. That's all.
Oh, yeah, I put the logo up.
So how do you actually switch
So,
every time?
And I still have some of the confusion on both rooms. Is it capital PASS, the password for the Versatech? 0600 exclamation mark. So pass 0600 exclamation mark, the password for the Versatech.